Okay, my name is Shuji Rai, and this co-moderator is Professor Si-Hyun Bae and Professor Osamu Yokosuka. And now we would like to open this session. And the first speaker is Dr. Kuo Chao Lee, Singapore. Yeah, please start.
So very good afternoon to everybody. I'm Kuo Chao Yu from Singapore. I work in Tan Tock Seng Hospital. Thank you for this opportunity to talk on this very complex topic. I'll try to actually simplify it for you. After a month of eating the frog on this topic, basing on what Prof have actually taught us to actually concentrate on a small portion each day. So I have nothing to declare of a conflict of interest to this lecture. So if you actually see what is actually the global burden of liver disease today, there are 2 million deaths annually for cirrhosis, viral hepatitis, and liver cancer, and now the MASD and also the alcohol liver disease is actually on the rise, and all 4% of the deaths worldwide, 1 out of every 25 deaths. 11 leading causes of the death worldwide, 9 in South Asia, and the 15 leading causes of disability associated life years lost, especially in the young. So if let's say we look at the world map here, and some of the region in the world that is actually, as compared to 1990 and compared to 2017, that's actually on the rise in terms of the burden of the liver disease. And this is actually show a similar pattern in the social demographic index throughout the whole world. So there's actually unmet needs for liver transplant. It's the second most common solid organ transplant. But however, it's actually less than 10% of the global needs of organ transplantation are met. As well, you can see the US graph here. The kidney, they receive most of the, transplant, and the liver, 10.7K, but still got still about 9K is actually on the waiting list. So there's actually 11.3% decrease in the liver transplantation globally in 2020. And there's actually mostly actually from a disease organ donation. And so what you can see here in this graph at the left lower part, there's actually Southeast Asia, and especially in this region, the organ transplantation and organ donation isn't actually a culture. So we are actually excited with this xenotransplantation news actually released early, this month. In which China have actually successfully transplanted the liver of the gene-edited pig, which was used without the hyperacute rejection. I believe actually up to today, there's still no hyperacute rejection. But however, this xenotransplantation is still considered very expensive, and you need to consider the infections rate from the zoonosis, and also we actually have to cultivate the pigs in the very specialized lab environment. So it is actually a very expensive, the healthcare issues here. So for the liver, it is actually the largest gland, and it has multiple function, inclusive of carbohydrate metabolism, protein metabolism, lipid metabolism, drug metabolism, and production, and also excretion of the bile. So with the organ is such many functions, then there's actually quite difficult for us to actually achieve, to generate something which actually can actually function for, they have a function for all these, the liver functions in a single cells. So there's actually also a vast, the spectrum of the acute and chronic liver failures. In terms of etiology, we have a viral hep, we have a metabolic liver disease, and the list go on, and all this will lead to end-stage liver disease. And can liver regeneration be the future? Now, so we probably have to actually understand nothing is actually so straightforward. Then we actually see how we can actually learn from the pathway and also the cells transformation. in terms of liver injury regeneration, which is actually complex and also a dynamic process. And there's actually an upregulation of a gene in the cell cycle progression, DNA repair, and also the mitochondrial function alteration. And all these things leads to a proliferation and differentiation into the functioning hepatocytes. And all this needs multiple signaling molecules to regulate it in the direction of a liver regeneration. However, with chronic liver disease, inflammation and everything, and also with aging, all this can lead to dysregulation and also impairment of this pathway, and also leads to the opposite direction. So what have we learned? 10, 15 years ago, when the scientists are actually able to demonstrate, if let's say we actually perform a partial hepatectomy up to 70%, on the mouse liver, the liver will try to actually regenerate back to the original size of 100%. This is something very miraculous. And at 100%, then the liver will stop regenerate further. So there's actually a termination process. And in this process, what we further actually discovered is actually, even though there's actually no hepatocytes that actually can regenerate for us, and the surrounding cells, inclusive of bile duct cells, can actually transform into a liver progenitor cells, and also the bile duct cells also can transform to the hepatocyte directly. So this has give us some flexibility in terms of differentiation of the cells. And the mice actually following the partial hepatectomy, what you can see here, 7 days after hepatectomy, if let's say more than 2/3 of the hepatic mass is actually removed, then the liver regeneration is actually inhibited. But if actually less than 1/3 is actually removed, then hepatocyte will start to proliferate and in fact to give you hypertrophy. So this is something very interesting. And once it's actually restored to the original mass, there's actually no formation of a new liver lobes and also lobules. So this is something we actually triggered the interest of the scientists. And from there, we start to actually explore what happened actually inside the cell. So there's actually episodic alteration in the gene expression, and this pathway is actually very tightly regulated in terms of the hepatocyte stimulation. Some of the gene upregulation will cause mitoinhibitory and also cytocidal, means the kills of the liver cells. And some of the gene alteration will induce the pluripotent stem cells. And all this signaling will actually go through the autocrine growth factors production to actually stimulate the gene expression further, and ultimately have a hepatocyte proliferation and also differentiation. I try to summarize what happened. In the liver cell, in the cells after the hepatectomy. So what you can see here, it's actually rather precise that within a certain time frame, certain things will actually happen. And the graph on the right upper part is actually summarized that there's actually upregulation of DNA and subsequently followed by the liver mass production. However, what is actually still unclear here is actually a termination of the liver regeneration when there's actually, the tend to cease is actually the least understood. And at the termination of liver regeneration, what the observation are is actually a restoration of the extracellular matrix and differentiation of a hepatocyte, and also there are expression of the 250 gene post 14 days beyond the partial hepatectomy. So there are also extracellular signals, which is actually summarized in this busy slide. However, in summary, those actually are complete mitogen, such as hepatocyte growth factors, and also the other ligands can cause liver enlargement and hepatocyte DNA synthesis and proliferation. However, there's actually auxiliary mitogen, in which is actually not the fundamental to cause liver proliferation. However, without them, the liver will actually not proliferate. And there's actually some other signaling pathway which actually, will crosstalk to each other, in which is actually very complex to understand at the moment. So what is actually new in the liver bioengineering? So the advanced liver engineering, I can actually summarize in this. There's actually a biomaterials fabrication and decellulization of liver scaffold and the reconstruction of 3D tissue architecture. And self-engineering through a genetic manipulation, we just change the gene of the cells, and then also we modulate the signaling pathway, and we use the nanoparticle to actually enhance the delivery system, and also use the microRNA and genetic manipulation to detect the cells to actually go under hepatocyte lineage. So it's one of the examples here is actually, we can actually cultivate the liver from a human, the porcine, also the mice, and we decellulize them, and then while maintaining the structure, and after we cut it into a small cube, and it can be in the cube, in the layer, or in the enzymes, in the culture media. Then after that, we inject them with the cells that we want. So if we need the cells that are actually functioning, one of the ways is actually to import it. And how are we actually going to import it? I mean, in the subsequent lectures, they are going to actually, the professor is going to touch on this part. So we have a stem cell, and this paper actually summarizes quite nicely what happened. And the year 2022, that's mostly the stem cells actually taken from adipose tissue, umbilical cord, bone marrow, blood, such as menstruation blood, and also the liver. And they are effective in the liver fibrosis and cirrhosis regression, and the less invasive than the patients as compared to the transplantation. And mostly actually stay in phase 1 and phase 2 clinical trial, but we did see a few, like 6% and 1.3% in the phase 3 and 4 respectively. So there's actually some ethical restriction in terms of cultivation, and the most widely used is a bone marrow stem cell, and then many people are actually using the umbilical cord and also the adipose tissue. And the delivery pathway is actually mostly through hepatic artery. Some of them is actually using intravenous and also the portal vein. The problem with intravenous is actually mostly will actually go to the lung and not the liver. So these are the advantages, and it's not my intention to actually go deep inside, because in the subsequent lecture, then you'll learn more about it. But however, a successful self-therapy will require efficient process from harvesting, culturing, phenotyping, differentiation, maturation. Then after that, you deliver back to the patient, and then ensure it's actually engraftment and without any rejection. So mesenchymal stem cell therapy, for example, mostly actually use a bone marrow and umbilical cord through the allogenic mesenchymal cells. And what they found is actually, if let's say the distant, the second injection is actually more effective, and you don't need to use a high dose. You can just use a low dose, but you actually ensure multiple injection with a longer interval, and it can reverse the Treg and T17 cell ratio, which is actually undifferential. The T cells, so that they can actually change, the direction for the macrophage, and also after that subsequently differentiation into the hepatocyte cells for the progenitor cells. So talking about the macrophage, and this is some advancement. If let's say we don't have the cells, we can also ask the surrounding cells to actually function, to actually promote the liver regeneration, because the macrophage is actually functioning to actually remove those dead cells, and also through the autocrine kind of the interaction is actually trying to actually recruit the white cells to the liver, and also encourage the liver cells to regrow. So some of the macrophage will stay as a macrophage, as a baseline. Some of them actually differentiate into cover cells, and some of them actually differentiated into the hepatic macrophage to promote liver regeneration and liver injury. So what can we do? If actually we can actually cultivate from the macrophage from the peripheral blood cells, and we do the metabolic reprogramming, so that to actually change them into the liver-specific inflammation-resolving macrophage. And from there, you can actually infuse back the macrophage there, so that it can actually go to the liver and ask the liver to actually regenerate. So this is actually a very nice study performed. And the authors actually using a macrophage therapy using the bone marrow stem cells, and bone marrow cells actually improve liver fibrosis and regeneration. Then what the team saw was actually a reduction in the hepatic myofibroblasts, which is myofibroblasts, which is actually followed by the reduction in the fibrosis 4 weeks later. And this has been commented to actually involve a paracrine activity. And there's actually another study, it's actually a phase 1, the dose escalation trial, in which, if you can see, the study team actually divide the patients into 3 groups, and then in the lower cells group, and then also the higher cells group. And what you can see in terms of the melt improvement for the higher cells group is actually, you can see that the pre and post, they does actually improve. And in terms of fibrosis markers, there's actually a marker improvement in the fibrosis marker after that. And in terms of safety, mostly it's actually acceptable. Some of them have the abdominal pain. So nothing is actually, fatal, and most of the patients survive after a year. So how about all the other things like we explore the eosinophil function. As well, you can see that it's actually quite prominent now in IBS and functional dyspepsia. And liver regeneration, using the eosinophil is actually have been actually characterized by the eosinophil will attract the macrophage to come into the liver and start the regeneration process. And if, let's say, we don't have a cell, we can't cultivate the cells, then we need the cells, then how do we do it? We create it. So what we can do is actually using the small molecule identification to actually generate the renewable sources of a functional human hepatocyte. In this, it gives us, empower us with the repetition. It's actually quite easy for us to actually replicate it. And in this study, using the high trial liver screening platform, that match the functionality of the liver, and from there, they can actually identify certain molecule that can differentiate the cells into the liver lineage. And this small molecule-driven protocol over the right side also, have telling out the protocol is actually telling us that this step is actually possible. And but a single cell is not the answer, because the single cells, you still need to actually cultivate them, and then in the 3D kind of, the structure, so that they can build up an organelle. So as what is actually exemplified by this, there's actually induced pluripotent stem cell, actually could support the component liver function, and after the several days of cultivation, you can start to see that the organelle start to form inside, and this organelle can be actually used to actually deliver to the liver for regeneration. And what we actually found here is actually liver cells differentiation over the spectrum does have a different type of the upregulation in terms of gene. And actually what you can see on the left side, for the cells at the intermediate and also in the, not the liver, the lineage, the early phase, then the gene, the set is actually a little bit different, and hepatocyte, the gene set is actually complete opposite. And we have the technology of microRNA for the genetic manipulation, in which what you can see that at the baseline, the embryonic cells have no protein expression, as demonstrated by the number 1 and the number 4. And after 4 months, you see the phenotype of the cells is actually quite near to the normal cells. So we have the technology to actually differentiate the cells. And after that, then of course, you need to cultivate the cells, you need to maintain it. Then there's actually other technologies such as the nanotechnology, the nanofiber, and use a 3D printing to actually build up the home for them, and so that you can actually infuse the cells and cultivate them, but you must ensure them that to have sufficient nutrient and also oxygen, and also while you're maintaining this, you must also make sure that you don't actually kill off the cell because of the physics. And what is actually important also, this discovery is actually not all the cells, inside the liver lobules actually will regenerate. So what we discovered recently is actually the cells in actually the center will be the one actually target for the regeneration as well. And I would actually like to actually, take this chance to actually highlight the polypeptidization, in which in lay term means that cells actually carry multiple sets of a chromosome. And this is actually a cellular defense mechanism in which that, that with the aging, with the liver injury and everything, and these things actually going to get upregulated, and you reserve the genetics material so that you can actually slow down the destruction to the liver. This is something actually very interesting. And what we can see that with aging, then the population of the cells, which is actually tetraploid or the octaploid, and you start to actually become, different from the young. But however, probably from what I can perceive here is actually the octaploid are those a survivor. So that's why they are still there and then they proliferate themselves. And for those actually cells actually enter the senescence, it's actually quite difficult. But however, there's actually evidence whereby you can actually mold them back to the polyploidal the state, and this thing in the very young liver microenvironment, and this thing can happen. So it means that the damage done can be actually reversed. And in the lobule, the distribution of the polyploidy is actually different. So I'm not going to go deep inside. And in fact, there's actually a metabolic zonation, and this is actually very important for us to actually discover the mechanism and also the drug discovery. And also, we understand that there's actually a telomerase, in which is actually an enzyme that's actually used to actually to repair the gene when it's actually damaged. And so what you can see over the graph here, after a liver injury, the induced liver injury, there's actually upregulation of the telomerase in the cells, and subsequently after that, when the repair is actually done, then it starts to actually quiet down to the baseline. And we also need to actually understand that we have the opportunity to actually use the oligonucleotide-based therapy rather than therapy, in which, because the cell therapy is actually rather difficult to cultivate. Then how about acellular therapy, like this small, interfering the RNA, so in which we can actually use a specific technology such as the dendrimers to deliver the cells to the liver target, and we have the lipid nanoparticles now, so that we can actually avoid off-target kind of side effect. And then, once actually delivered into the cells and get processed, then even together with the CRISPR, then we actually change the genetics and get a genetic modified cells. So, and I will enter. This just also demonstrate that we can actually, modulate the cells so that they can actually go under the path of the hepatic lineage. And cell-free based therapy will be described by the subsequent professors, and especially on the extracellular vesicle. And this is actually something exciting, in which that you cultivate the proteins or the RNA, the genetic material into the exosome, and it's delivered into the body of the patient to regenerate. And what actually happened here is actually they use dendritic cells, which is actually transfected with the modified gene, and they delivered to repair the osteoarthritis in the mouse. This is my second last slide, sorry. So, and to enter in the future of the liver regeneration. And we already discovered recently there's actually a partial reprogramming possibility that we can reprogram an adult hepatocyte, which is actually not able to reverse back, in the past, to the progenitor state of cells and ask them to actually to proliferate. Then after that, we can actually cultivate them and send back to the liver. And this is something very exciting. And we have the first-in-class small molecule inhibitors, which was actually discovered through the nuclear magnetic resonance spectroscopy, which is called the MKK4 inhibitor, in which that actually, the medication allowed the survival of the pig in the later 85% of hepatectomy, in which after you remove most of the liver and you provide this MKK4 inhibitor, then the liver is still able to sustain the life. So then they have already moved to the first in human phase 1 trial, and they have excellent safety and also pharmacokinetics. I will encourage you to actually have a look at this paper if you have time. And this is actually something exciting for us. So in conclusion, our grasp in liver regeneration has significantly broadened, moving beyond the traditional concept of a hepatostat mechanism after the liver resection. Chronic liver disease will interfere with liver balance, leading to inflammation, cells loss, fibrosis, and also cancer. And there is a pressing shortage of the organ donors, and which is actually intensified by the focus of regenerative medicine in the liver. So liver regeneration have a chance to be the future for the liver regression, and the liver tissue engineering reveals a new insight into disease mechanism, potential treatment, exploring the self-dynamic signaling pathway, and there's a breakthrough in the regenerative techniques such as DCR scaffold, 3D bioprinting, nanotechnology, facilitation of the creation of functional liver tissue, and although all these things not straightforward, but the future is there. So thank you for your attention for this lecture.
Okay, thank you very much. Yeah, time passed quickly. Thank you so much. Okay. And I would like to introduce the next presentation is Professor Taro Takami. He is now professor of the Department of Gastroenterology and Hepatology at Yamaguchi University. Okay. Professor Takami, please.
Thank you very much for your kind introduce me. So I'm Taro Takami from Yamaguchi University. I'm very happy to share our work about liver regeneration therapy using autologous bone marrow-derived MSC for decompensated liver cirrhosis. So our target patients are suffering from liver cirrhosis. Liver cirrhosis, dense fibers deposit in the liver, so that the dense fibers halt hepatocyte proliferation. Normal livers have higher strong regenerative capacity. However, liver cirrhosis loses this regenerative capacity. So that we would like to develop regeneration therapy to reduce liver fibrosis. This is a current clinical trial schema. At first, we would aspirate small amount of bone marrow fluid under local anesthesia, and then shipped to cell processing facility in Ishikawa Prefecture. In this cell processing facility, bone marrow-derived MSC fraction was expanded using robot system culture with non-serum medium developed collaborate with Ajino Corporation. We expanded bone marrow MSC and then frozen. After checking the quality, we transferred these stock frozen bone marrow MSC into our hospital, we then infused into the same patient through hepatic artery. So that this is our development of liver regeneration therapy. Upper panel shows the current approach, small amount of volume, bone marrow fluid, and robotic system, and also using the non-serum medium, and also injected MSC through hepatic artery. This approach is based on ABM therapy, bottom part. That after me, probably Dr. Terai initially developed this ABM therapy. Probably he will present briefly. So that in this ABM therapy, we collected 400 milliliter bone marrow fluid and general anesthesia, and wash and concentrate bone marrow mononuclear cells, and they wash and infused into the same patient by drip infusion within same hospital day. So that the ABM therapy includes general anesthesia, so that it is difficult for whom general anesthesia is difficult. So that we have started to develop less invasive liver regeneration therapy. From ABM therapy to current approach, we changed several factors. At first, we changed the infusion route from peripheral vein into hepatic artery, and also change the medium from 10% bovine serum medium into non-serum medium, and also we changed the culturing method from manual into robotic automatically system. At first, we like show the change of infusion route from peripheral into directory. This result of Muri model. Lower panel show that result after peripheral infused mice. As you see, there are many cells are trapped in lung, and also they disappear within a few days. However, lower panel show that these cells were infused from spleen through portal vein and directly injected into the liver. Around 3 times of the cells were migrated into the liver, and longer time we can see migrated in the liver. So that we wanted to change the route from peripheral into directory route. But we are internal physicians, so it's difficult to inject cells through hepatic portal vein, so that we speculate probably hepatic artery direct infusion may be effective than peripheral. So that we developed this canine model. We inject carbon tetrachloride treatment directly into the stomach for 10 weeks. We developed liver fibrosis. After developed liver fibrosis, we injected bone marrow-derived MSC into the liver through catheter, a similar technique as HCC treatment. After MSC infusion, we assessed the kinetics of liver fibrosis serially, histologically. As you see, hepatic artery direct group shown in red had the highest effect on liver fibrosis than those in peripheral group. Therefore, we decided to change infusion route towards hepatic artery. Moreover, we injected 3 times of bone marrow cells rapidly because of some researcher concern MSC may promote procoagulation activity. So that we checked after MSC infusion, we didn't show that any procoagulation activity. Also, we did not show no defect in liver, showing no MSC thrombosis. Moreover, some research have concern that MSC may accelerate hepatocalcinogenesis because MSC have immunosuppressive capacity. So that we developed this liver fibrosis with hepatocalcinogenesis murine model. 2 weeks after the birth, we injected DNA and to induce tumor. And also, we induced liver fibrosis by carbon chloride repeatedly. So the 4 times injection of MSC, we assessed the kinetics of hepatocalcinogenesis, including bearing rate and number of tumor and size of tumor. As you see, we did not find any acceleration of hepatocalcinogenesis after MSC infusions. So that we absolutely agree with the increasing number of MASH-related liver cirrhosis worldwide, including Japan. So that we would like to assess the safety of and efficacy of this MSC infusion in MASH murine model. After MSC direct infusion through spring, we could confirm reduced peripheral fibrosis. And interestingly, we confirmed higher number of M2 type macrophage than M1 type macrophage. Probably MSC may promote a phenotype switch of macrophage from M1 to M2. Previous speaker already showed that. So that in vitro study, we confirmed this cell-cell interaction between MSC and macrophage. After MSC co-culture with macrophage, some MMP genes in macrophage are upregulated, and on the other hand, inflammatory cytokine TNF-alpha was decreased, considered with inducing phenotype switch of macrophage by MSC co-culture. Moreover, interestingly, we found that improvement of the fatty liver after MFC infusions, so that we confound beta oxidation is enhanced in mitochondria to reduce fat deposition, and also confirmed decreased fat deposition in HepG2 co-culture with free fatty acid after MSC incubation. So that, and also we have developed a new non-serum medium for MSC. This stem fit for MSC already available in the world. And in this medium, we can expand MSC more high quality MSC because as you may know that probably that lower level of inflammatory cytokines and lower level of cell senescence markers. On the other hand, MSC maintain an anti-inflammatory cytokine TSG6 and so on. And also we changed the culturing method from manual into a robotic system. This robotic system is in isolator, and isolator connected with incubator and centrifuge. Therefore, we can cultured for several weeks under aseptic condition to prevent from bacterial infection. So that is criteria. Inclusion criteria is age from 20 to 75 years. And liver biopsy is not necessary. We need confirmed liver cirrhosis by imaging examination, including CT, MRI, and also FibroScan analysis. Moreover, the Child-Pugh score ranges from 7 to 12, and etiology of liver cirrhosis is not questioned. And the exclusion, we exclude alcohol drinking within 6 months, and also the risk of rupture varices, and also the within neoplasm, including HCC. We'd like to show the first two cases because we could observe for around for 2 years. The first case, she was suffering from decompensated liver cirrhosis caused by alcohol consumption, but she stopped alcohol drinking more 1.2 years. But she still suffering from decompensated liver cirrhosis. After her received MSC infusion, gradually liver functions improving, consistent with higher level of albumin and 50% decreased total bilirubin level. Child-Pugh score from 9 to 6. Moreover, several fibrotic markers also improving, decrease. And also we confirmed elasticity by MR elastography. Before the MSC infusion, we confirmed her liver higher elasticity, meaning her liver shows red. However, after MSC infusion 1 year, changed the color from red into yellow, and her volume also around 900 into 1,000. Currently, already 2 years past, her liver volume already 1,200 milliliter. Second case, he suffering from the HCV-related decompensated liver cirrhosis. HCV already eliminated by direct-acting antivirals, but however, his liver functions is still Child-Pugh class C. Therefore, after received his MSC infusion, albumin level relatively rapidly increasing after MSC infusions. He didn't see never had this around 35 point albumin level, but and also Child-Pugh score from 10 to 7. Now we have been conducting this clinical trial in four cases now. Therefore, we could patient-derived MSC from 3 patients, and also during developing this therapy, we have 3 MSCs from healthy donors. So we can compare the expression profile microRNA from including in extravesical from MSC. In this slide show that almost microRNA pattern are similar. So the 36 of 40 almost same. Probably this slide suggests that probably MSC from patient may have potential to cure their liver cirrhosis, I think, similar to healthy MSC. So that we screened the underlying mechanism of this selected microRNA. Finally, we found 5 microRNA characters could reduce liver-related genes into hepatic cell lines. As you see, after 5 microRNA character supplementation, several fibrosis-related genes are downregulated. Also, IP analysis show that these 5 microRNA characters downregulate low S signaling. As you see, after microRNA character supplementation suppressed cell migration. probably cell migration of hepatic stellate cell is correlated with activation of hepatic stellate cell. I think so. So this is my final slide. We'd like to show the positive mode of action. We expand higher quality bone marrow MSC using non-sterile medium, meaning lower level of senescence and higher level of maintain anti-inflammatory cytokines, so that we injected these cells into the liver directly, and this MSC may promote phenotype switch of macrophage from fibrotic macrophage into fibrolytic macrophage. Also enhance beta oxidation and reduce fat deposition to increase blood flow. Probably microenvironment is improving. Also, the MSC, if we derive the microRNA directly, suppress activation of hepatic stellate cells. So that after that, this liver function, liver improved naturally by themselves. Now we have been conducting false cases. We'll do the best to achieve the approval of insurance. Thank you for your attention.
Thank you very much, Professor Takami. In now open discussion. Yeah, okay. Meantime, is from me is you showing is your clinical trial is showing is after 3 cases you dying and response is aluminum level increasing is more longer time. How do you think is why the mesenchymal stem cell infusion is affected more long time?
Yes, it's a very good question. In our clinical animal data, already the MSC disappear within 1 month. However, that in clinical trial, we can see liver functions improving after 6 months. Probably that macrophage also contribute to this improvement. And also now I found that some secreting protein from MSC promote progenitor cells. But I didn't show that. But probably some derived factors from MSC may contribute to improvement of liver functions.
Okay.
Yes. Thank you for your successful result in your clinical trials. Excellent, very excellent. So my question is that you mentioned the cell and cell interaction between the bone marrow mesenchymal cells and the macrophagy. So do you have any explain the mechanism? There is some in the report that there's some exosome from the MSCs. The MSCs exosome can interact with the macrophage immune cells. So is there any mechanism in your clinical trials?
Yeah, it's very important. So, but I show the exosome for the interaction with the hepatic stellate cell. Probably some another microRNA may affect on the macrophage. But now we are screening now. But anyway, so the 5 selected microRNA cannot induce phenotype switch in macrophage. Probably that another microRNA may be involved in the phenotype switch. But also, but I don't know. Yes, but probably that possibility that now we are screening now.
Did you analyze the exosome profiling when you transplanted the cells? Could you?
No,
not yet. Okay.
Okay, other question. Okay. Okay, do you using the microRNA 5? Okay, okay, go ahead. Okay.
Thank you for a very excellent talk. So can I actually, you mentioned just now that the liver cirrhosis patient-derived stem cells works better. Yeah.
Yeah.
So any explanation for that?
No, not,
Or it's just an observation at the moment?
yeah, not yet.
Okay, thank you.
Okay, other question? Okay, time come. Thank you very much.
Thank you very much.
Okay, so the speaker. I introduce the third speaker, Suji Terai. It's my honor to introduce Professor Suji Terai. He is now the chairman and professor of the Division Gastroenterology and Pathology, the Niigata University. So today he will talk about the development of a regenerative therapy for liver cirrhosis, mesenchymal stem cell, HMGB1 peptide, extracellular vesicle. Please.
Okay, thank you very much to give me a chance to present it here. I would like to present my data. Yeah, this is my COI. Yeah, we are now trying to do making a new therapy. This is a liver cirrhosis condition is a point of no return. Have to recovering this condition is the most important step. And I myself had doing a study in NIH. Professor Takami is also doing a postdoc in the NIH also. I come back to Japan to 2000. I started to developing ABMI therapy. This is a clinical study. And finally, I also doing autologous bone-derived mesenchymal stem cell for decompensated liver cirrhosis. Professor Takami is showing this data. And I shifted to the Niigata, and I started to the allogeneic mesenchymal stem cell. That is derived from adipose tissue. And I doing a decompensated liver cirrhosis and compensated liver cirrhosis. Compensated liver cirrhosis is a doctor-initiated clinical trial. Now I'm trying to do the exosome therapy. Another part is that this is a cell-free HMGB peptidotherapy. That is induction of the mesenchymal stem cell. And this is, I think, now in Japan is promoted regenerative medicine. And the important point is that we have to knowing it what condition when you use it, which have to use in regenerative medicine, because there is a very, very important step. Now is the time is shifted. And I myself is doing a clinical trial flow. This is a mesenchymal stem cell. Road company is supported me, and I also doing is doctor-oriented. And the other part is HMGB1. This is induction of the mesenchymal stem cell. And I also doing initiated study. And now trying to making, this is only a basic study, but I would like to making is EV therapy. And this is in doing is Yamaguchi University is we started this autologous bone marrow cell infusion therapy 2003. 2003, November 14th is that is general anesthesia getting is 400 milliliter bone marrow cell and to getting mononuclear cell and infusion. And we finding is albumin level is improving, child score is improving, and this is a good responder. Liver cirrhosis condition is improved. Please comparing this and this. And this patient is at the time albumin level 2.7, and this patient is surviving 18 years. Yeah, that is good responder. Anyways, I going to the Korea doing is Yonsei University. At that time is I'm young time is I'm meeting Professor Bay. At the time is yeah. In Korea is doing 20 cases. I'm doing Yamagata is alcohol related and HIV and HCV National Center of the Global Health, and also doing is Okinawa is a NASH related case. And this is chunking came is showing is the procollagen level is a decreasing thing is. And important point is this clinical study is autologous bone marrow cell infusion, which cell is affected is at the time. But the important point is the human cases is this is biopsy. Please compare before ABM therapy. This is 1 month, and PCNA positive cell is increasing. This is coming from the Ionse group's data. It's 1 month, 3 months, 6 months. They're getting a liver cell is the catheter-induced liver biopsy and find the CK7 positive hepatic progenitor cell is increasing. This is very important clinical finding. And this clinical study we finding is liver cirrhosis condition is very tough. Fiber is there, so is regulation is a liver fibrosis to activate this regeneration. because liver itself has the capacity of the regeneration. And it is very, very important key concept is one of the proof from human case. And Professor Taro Takami is doing the good work with to developing. And because it's autologous bone marrow cell infusion therapy, this patient is getting a general anesthesia. There is a very limitation. And 50 patient is coming, but in one case we can doing is this study. And so is we doing is local anesthesis get small amount of the bone marrow and infusion of the mesenchymal stem cell. This study now is automatic system is Professor Takami is doing. And I shifted to 2015, it's shifted to the Yamaguchi to Niigata. And I would like to know why ABM therapy is affected. And I doing it 50 years. And so I shifted to allogeneic mesenchymal stem cell. And this is a basic study clinical trial. And I asked Dr. Tsuchiya is to the bone marrow cell is a small amount of mesenchymal stem cell. And this is including macrophage, which cell is the most effective to improve this function. We're making, this is basic study, carbon tetrachloride infusion and making ribociclib. This is serious staining as a mesenchymal stem cell and bone marrow cell and half and half, 50% infusion. And we're finding that 50% infusion is the most effective. Of course, mesenchymal stem cell and macrophage also improving. And we're doing is, this is a 2-photon excitation microscopy. And in vivo study, we're checking it, which cell is repopulated now. And bone marrow cell is a green color. Red color is a mesenchymal stem cell. And we're checking is the repopulation, half infusion of the peripheral vein. And finding is, this is very important data, is majority of the macrophage is stay day 1, day 3, day 7. After infusion, that is there in liver. But the mesenchymal stem cell is stay in liver is day 1, and majority is stay in the lung. So this is blue color is fiber, and green color is macrophage. Please showing. Blue color's fiber is decreasing. This is just in vivo imaging. Okay, from this point is this is our previous analysis is that is just we finding it. This is a basic study. 2004 at the time is GFP positive bone marrow cell is a repopulated liver and liver fibrosis improving. But the important point is this cell is majority is a macrophage. That is we can getting this data. And now we're thinking is mesenchymal cell is a conducting cell to regulate the regeneration and inflammation. And many cell is repopulated mesenchymal cell to the lung, and working cell is macrophage. Macrophage shifted M1 to M2. And mesenchymal stem cell, we can getting is adipose tissue. Of course, we can getting it umbilical cord and bone marrow. But is to thinking is to generalize the regenerative medicine. I shifted to adipose tissue-derived mesenchymal stem cell. Okay. My friend is Stuart is doing autologous macrophage therapy, Edinburgh. Yeah, he himself is a macrophage. It's very important all time. He is doing allogeneic autologous macrophage therapy, and phase 1 is shifted, and now he is trying to do the phase 2. He presented the phase 2 study. And we are now thinking is to doing allogeneic mesenchymal stem therapy. We're checking is interaction of the, this is a mesenchymal stem cell, and this is shifted to toligenic regional differentiation. And allogeneic mesenchymal stem cell is MH class 2 is negative. So at that time, we started clinical trial. We will need it immunosuppression agent or not. And other part is we checking it. This is a co-culture of the mesenchymal stem cell and macrophage. And we finding is mesenchymal stem cell shifted the macrophage to M2 phenotype. So we started this clinical trial 2017, allogeneic adipose tissue derived mesenchymal stem cell. This is CHARP B, NASH and HCV related patient. And this is adipose tissue-derived mesenchymal stem cell and to getting. And this is we designed it without immunosuppressive agent. And we are preparing this cell is coming to the Niigata University Hospital from Roth Company. And we use infusion 1 hour or 2 hours. And this is a decomposite. We're doing a phase 1 and phase 2. And also is important point is fortunately we finishing is phase 1, phase 2 trial. And the other part is a very important thing is we are firstly to doing a decompensated reverse cirrhosis patient, autologous bone marrow cell infusion therapy 2003. At the time is we started the new stem therapy, and so we selected the decompensated reverse cirrhosis patient. And allogeneic is the mesenchymal stem cell. We're doing is adipose tissue mesenchymal stem cell child to B. But is we can finding a safety, and so we shifted this child to be a patient. So we can checking is which timing and which cell is the most effective. And more important point is that we also doing is a clinical trial, more long time follow-up study. These are also very important to thinking is a cell and stem cell-based project. And anyway, other part is during this time is recently liver fibrosis evaluation system is very much progressed. And so is I also doing the other part is mesenchymal, but is HMGB1 peptide therapy also. This is a carbon tetrachloride induced, and this is a HMGB1 peptide and to induction of the mesenchymal stem cell. And this please comparing, this is control, this is HMGB1 induction. 4 weeks after, please compare this and this is liver fibrosis is improving. So we making is a trial, and this is investigator-initiated clinical trial. Phase 2 started in 2020, and this is case registration is completing, and now I'm analyzing. And now we also checking, and this is MRI elastography, ultrasonography, and recently some serum marker is available now. Yeah, this is one case showing this is before doing HMGB1 therapy, but is pre-comparing is the 162, and that is elasticity is improving in this patient. Yeah, I think is to thinking of the liver cirrhosis patient is to using a stem cell macrophage is a very key point. Yes, we're doing is some study is comparing a cell and HMGB1 and exosome, and we're finding the macrophage is one of the key points. As a part of the Edinburgh group, is my friend Stuart is doing is macrophage therapy. So we're doing also exosome therapy. Exosome is one of the very, very important target. It's 100 nanometer size. And we are to thinking is mesenchymal stem cell is a majority depopulated lung, but is working is a macrophage in the liver. And there is something in the relationship. So I think is the exosome is very important. And this is some basic study to doing is interferon gamma induction mesenchymal stem cell secreted the exosome. Exosome is changing macrophage to M2. And this is M2 is shifted. And other time walking, moving is increasing. This is a control. This is EV adding thing. And content of the MSC-derived exosome is annexing, actotransferring, aminopeptidase is one of the good marker, I think. And to infusion of the, this is a carbon tetrachloride reverse cirrhosis making. This is a basic study, mesenchymal stem cell, EV induction. Yeah, mesenchymal stem cell, please compare this and this, and mesenchymal stem cell infusion. It is okay to improving liver fibrosis, but the EV is okay to improving. And what was happening in here is that we asking, analyzing, single cell analyzing, and we finding is that anti-inflammatory macrophages increasing T cell, and regulatory T cell is also increasing. And we're thinking interferon gamma derived mesenchymal stem secreted exosome, and this is a very key point. And we press release these things. And next step, we have to using this easily is clinically. And many people is looking for how to using EV. Now, this is to thinking of the liver, it is only just is a basic study. Peripheral infusion of the EV is a majority is repopulated to the liver and lung. And that's very quickly to shift it. And this is a previous paper, so we ourselves is doing. And in clinical field, mesenchyme-derived exosome therapy already done. This is the Austria group. It's my friend is doing is this is first in a human clinical study. And the important point is we also to checking is making a new system. This is a mesenchymal stem cell derived. This is a new system. It's a red color exosome is secreted. This is a 100 nanometer size. And we analyzing in vitro study macrophage, hepatocyte, striatal, and cellular cell. And we finding macrophage very easily exosome is to include it to the macrophage. And targeted macrophage. So this system is, I think, is EV might be okay to using in the liver cirrhosis patient. And other part, hepatocyte, hepatic stellate cell, and endocellular cell, not so much is captured exosome. So this is an in vivo study. Yeah, please focus here. This is macrophage. And we finding is red color exosome is depopulated to the macrophage. Yeah, in thinking of the clinically, yeah, the important point is the majority people, one part is to getting exosome, ultracentrifuge, but the other part is tangential flow system is very important. Yeah, our laboratory having ultracentrifuge tangential flow system. And we checking it. We can both to getting ultracentrifuge tangential flow system. So, yeah, we comparing, this is control, carbon tetrachloride infusion. This is tangential flow in perfusion getting is EV, and this is ultracentrifuge getting EV. Actually, the EV is important. I think the tangential flow is more good system to getting. And next step is preparation is a clinical practice. Practice is, yeah, we have to thinking of which cell have to getting. Firstly is the mesenchymal stem cell may be okay. And this is a mass culture to this culturing system, mass collection. And tangential flow as a system is very important. And the stop program and administration. Fortunately, in the liver diseases, it may be okay to the peripheral vein. And I think and cell stock. And other step is the regulation is very important step. And in Japanese Society of Regenerative Medicine is now making is how to using is this EV. Our group is to making this basic point is how to consider regarding preparation is a basic and their clinical application in Japan. And PMDA, Japan agency, drug agency also developed this thing. And various EV. Next step is now we also getting MSC-derived EV, but next step is engineered EV might be possible. And I myself also the member of the ISCT, and ISCT is now, this is exosome community. I am also exosome community, and so we are now thinking how to using exosome in clinically. Another part is in Japan. Yeah, we would like to taking care and have to using in the EV. And I decided, Japan Society of Regenerative Medicine is decided to using is a guideline, clinical application, extracellular vehicle. And I will be a chair, and we would like to thinking. The major point is that we have to using, because EV is a new therapy, we knowing risk profiling, manufacturing process, quality control, checking item, effective verification. Yeah, we try to summarize this system. Yeah, next April soon, and we would like to publish this thing is the next step. Yeah, I think I myself is doing a 2000 autologous bone marrow cell infusion therapy, and also doing is allogenic mesenchymal stem cell therapy, and as a part is the HMGB therapy. We would like to comparing these results Next step is that we would like to do the cellular vesicle therapy. Anyway, the important point now is a very important point is which system, which cell, which exosome is the most effective, and when and how to using this system is very important. Yeah, I think this is the original medicine is shifted to the articulated mode of action and articulated clinical trial. But sometimes reverse translation research and to go into the phase 3 and next stage is very important. This step by step is very important to making a new regional medicine. And I thinking is patients are coming to here, working to be better, and doctors are working to cure and working to change the future. And I think is we have to think in regional medicine with singularity. I think it's safe, security, effectiveness, clinical medical treatment with power enough. I think this is very important. And international competitive is also important. Thank you very much for your attention. Thank you very much.
Excellent talk, excellent research result. Your research result is highly completed, right? So among the many clinical studies, is there anyone have been approved by Japan FDA? Do you have approved them by the Japan FDA or expected in the future?
FDA?
Yes,
Concerning-
Japan government. FDA.
Yeah, of course, it's a government agency that supported us, and step by step is shifted. But I think is I now just finished phase 2, and next step is I have to design the phase 3. And the project is a little bit effective is only the clinical trial timing and more long time follow-up is a needed thing. And Japanese society regional medicine to getting a new disease database. And it will be very important step.
Yes, excellent, excellent. Okay.
Thank you, Professor Ji, for your excellent talk. So it's actually very exciting, but I noticed that you mentioned about the bone marrow and also the adipose tissue. Is actually a particular reason why you focus on these two and not umbilicus and also...
Okay, that is very easy because it's many people to getting the bone marrow is that is hematologic patient. We can getting bone marrow from donor, healthy donor, and healthy donor to getting bone marrow to making the bone marrow product to commercialize. This is sometimes it's inhibited socially. So I shifted this adipose tissue because that we can getting a plastic study to getting the adipose tissue very easily. So I shifted that.
Okay. And the other question is actually for the exosome trial, the study, the original design was actually look at the decompensated liver cirrhosis, which I think will be the most difficult, core to actually treat. And now, subsequently, over several years, then there's a focus on compensated liver cirrhosis. So is actually a reason for that?
Okay, I think I myself is doing autologous bone marrow cell infusion therapy firstly. At the time is nobody didn't doing this therapy. So at the time is more serious diseases we selected. And as the target is continuing 15 years old. Yeah, and I doing allogeneic mesenchymal stem cell therapy, clinical trial, we can getting safety. So we shifted this more compensated liver cirrhosis. So as the timing is new therapy, we are comparing is what timing is what fibrosis condition is the most effective. Yeah, this is one of the history.
Thank you very much.
Thank you very much. Nice talk.
Thank you very much.
Well, next and last speaker of this session is Professor Sihuan Weiss. He is professor of Division of Hepatology, Department of Internal Medicine, Penang St. Mary's Hospital, the Catholic University of Korea. And he graduated at Catholic University of Korea in 2000, and he became a professor of Seoul St. Mary's Hospital, Catholic University in 2010. and he is a professor of Yun Penyon St. Mary's Hospital. And from 2023, he is a president of European St. Mary's Hospital, Catholic University. He is Secretary General of APASU 2022 Seoul, and he is also president of APASU Single Topic Conference 2023 Busan, and that is a very successful one.
Thank you very much.
And he has got a lot of awards, but I have no time to say. And he's going to talk about next generation stem cell therapeutics for the treatment of liver cirrhosis from bench to bedside based on functional enhancement system. Professor Bai, please.
Professor Yokosuka, thank you for your wonderful introductions. I have nothing to declare for this study. Before talking about these titles, functional enhancement data was provided by Professor Ki-jin Kim, the Department of Biomedical Science, Cha University in Korea. I'll tell you in the following order. First, I will present the need of the clinical trials for patients with cirrhosis. Advanced cirrhosis, as you can see, the end stage of fibrosis is irreversible. And the cause of development, the hepatic failure and the HCC. Until now, there is no alternative treatment for the liver transplantations. However, shortage of donor liver and the surgical complications and the high cost limit the liver transplantations. The cumulative numbers on waiting list for liver transplant is still high in Korea. Therefore, clinical application of stem cell therapy is emerging as practical and promising. Next, the result of the preclinical and clinical study and investigator-initiated trials. As shown in the tables, several cells are used as cell therapy. Among them, MSC has used as a promising approach due to this advantage. Mesenchymal stem cells provide the benefit through the following mechanism. First, MSC is an immune-modulated response and inflammation. Second, antifibrosis, and third, provide the trophic agent factors to liver regeneration, and fourth, the direct differentiation into the hepatocyte. Finally, functional enhanced hepatocyte substitute the damaged hepatocyte. Like a picture below, in addition to the untreated, the use of untreated MSC, modified MSC therapy such as priming and gene modification and cell-free therapy may be promising and practical treatment in the future. In preclinical trials, the studies shows that the improvement of antifibrosis. Same as preclinical trials, clinical studies also show that the improvement in antifibrosis, liver function, and prognosis. This is my previous studies demonstrated the beneficial effects, some preclinical studies and the clinical study and SIT. Next, I'll show the sponsors initiated clinical trials. It's already begun. In 2020, for the first time, Korea, MSC was approved for the phase 3 for the patient, alcoholic decompensated cirrhotic patient. This MSC therapy was approved by the KFDA after efficacy and safety of autologous bone marrow mesenchymal stem cells for decompensated alcoholic cirrhosis was internationally recognized and accepted in the Hepatology 2016. This conducted multi-center randomized open-label phase 2 trial in which I participated as a PI. In this trial, the primary endpoint and the fibrosis, the second endpoint, the liver function, child-pugh score, and was significantly improved. Now, currently, phase 3 trial is on the way. Now, I will tell you about the functional enhancement systems in recent research. The picture below is the history of stem cells therapy. Since 2000, the mesenchymal stem cells study is activated, and then recently, functional enhancement MSC therapy is being studied. Looking at the method of functional enhancement, establishment as follows: the priming method, second, genetic modification, and through the viral and non-viral systems, and the third, co-administration immunosuppression with immunosuppressant and the scaffold. This figure below shows the genetic modification using a non-viral method and the viral method. For example, when MSC overexpressing IGF-1 based on adenovirus were transplanted into the fibrosis mice model, fibrosis is significantly decreased. In the right figure, in addition, when interleukin-10 secreting human MSC generated by gene editing were transplanted, fibrosis was significantly reduced and inflammation factors IL-1, TNF-alpha, interferon gamma was decreased. My co-worker, Professor Kim Gi-jin, produced functional enhancement placenta-derived MSCs which overexpressed PRL1 using lentivirus and non-viral vector systems AMAXA. As a result of analyzing the characteristics, it expressed the stemness marker and the PRL1 proteins and the cell surface markers through the PAX. Second method as a functional enhancement. As an example of a priming method, it has been reported that secretion from the adipose tissue-derived mesenchymal stem cells preconditioned lipopolysaccharide promotes the proliferation and the regeneration of hepatocytes by activating IL-6 signaling pathway. This proliferation was proved by increased expression of Ki67 that's featured the hepatocyte proliferation marker. On the right, the knockdown of microRNA 210 increased the survival rate and reduced the fibrosis in the animal model of acute liver failure. I will show that the PRL1. PRL1 is a member of the tyrosine phosphatase family. It was first reported in the JHEP 2002 as an early regulator of liver regeneration. Among the various functions, cell membrane penetrating function is very important. Our team expressed this placenta-derived MSC PRL1 improved the liver function of mitochondria and reduced the ER stress of the calcium influx that promote proliferation, regeneration, through the antioxidant effect. The functional enhanced placenta-derived mesenchymal stem cell PRL1 was transplanted bile duct ligation model. Figure C and D was significantly reduced in the transplanted group by 5 weeks. In our other reports, when functional enhanced bone marrow-derived MSC PRL1 was transplanted into BDL models similar to the placenta-derived PDL1 study, with the significant reduction of the fibrosis-related gene, ACTO2 and collagen 1 type 1, and the liver function, the AST/ALT and cholesterol and albumin level is increased, and the function is recovered. As an optimal condition for PRL1 peptide priming, optimal concentrations and the number of treatment and the time condition was set as follows. With this condition, PRL1 peptide primed the placenta-derived MSC, increased intracellular calcium influx and the AMPK activity. Looking at the right side, when PRL1 peptide priming, placenta-derived MSCs were co-cultured with the hepatic stellate cell, which activated TGF-beta, expressed the type 1 collagen, was reduced, and antifibrotic activity was increased. Let me talk about the therapy shortly. Already two speakers mentioned that exosome-prone MSC is a key factors in communicating between MSC and the immune cells, especially macrophagy, and may role in the fibrous regulation and the promotion of the regenerations. In order to identify the therapeutic efficacy placenta-derived MSC PRL1, our team is now analyzing exosome profiling that show difference in transplanted blood. Finally, now the bioengineering of in vivo liver mimicking architecture have been developed by using scaffold. Vascularized hepatic construct has been made from the encapsulation of a hepatocyte in the hydrogel, and the seeding endocellular cells can make the liver-like architecture. This is the last slide. We need to identify the safety problems, even if function-enhanced stem cell constructed through a non-viral priming system. Our focus on the advanced chronic liver disease. We are developing a next-generation function-enhancing stem cell treatment based on the PRL1 peptide priming. We are preparing to establish a standard for how functionally enhanced placenta-derived PRL1 can be used as treatment. It clearly quality in their mechanism of action. Thank you for your attention.
Thank you, Professor Bai, for your nice lecture. And the next generation stem cell therapeutics seems to be very promising. And I have a couple of questions or comments. How about how do you think about anti-fibrotic drugs, which may come in near future, comparing with your, stem cell therapeutics?
As I mentioned, that this is now under the clinical trials. Professor Tarai already performed many clinical trials now. So that I didn't know that there is a guidelines from about the exosome vesicles therapy. Therefore, even though we treated the antiviral therapy in the decompensated cirrhosis, but second speaker showed that the slide in the after achieving SVR, patient with the decompensated state, that using the stem cell therapy, after that, the volume is increased and the function is improved. Therefore, we do not do comparative the study of the antiviral versus stem cell, but these are another optional alternative treatment for the treatment for antivirus, because many companies are trying to make an agent for antivirus, but until now it is not succeeded. Therefore, the stem cell therapy definitely alternative treatment for the decompensated cirrhosis, I think.
Okay. Yes.
Okay. Now you are trying to do the engineered mesenchymal stem cell.
Yeah.
And I think it's one part is we finding is the mesenchymal stem cell somehow affected macrophage and to improving liver fibrosis and to induct it endogenous liver regeneration. And other part is itself is this cell is enhanced itself is liver regeneration itself is because it's previously HGF and because it's liver is orchestrally making its hepatocyte, bile duct cell, and stellate cell. And this thing is, do you think is your new engineered mesenchymal stem cell derived from placenta inducted this liver regeneration itself?
In our papers, I showed that the result from the using with the placenta, the functional enhanced MSC PRL1, so it has in the improved some mechanism of calcium influx and the MMPK activity and the antioxidant effect. So that there are many mechanisms to improve the liver regeneration and proliferation. So we do prove that some mechanism, and then that's prove the antibiotic effect. So, but it's very complicated to prove the proliferation and the regeneration. Therefore, we're still working the study about that some validated mechanism for the antifibrotic and the liver regeneration.
Thank you.
Any comment from the discussion? Professor Ye?
So thank you very much for this very inspiring talk. So you mentioned about the functional enhanced stem cell, yes. And you plan to actually use it in the ACLF. So because ACLF is actually a spectrum, and have you actually thought of on which type, subgroup of ACLF patient that you think that's actually will be beneficial in this?
We are preparing the clinical trials, and then we submit funding to the government about the target the patient with the muscle disease and with especially advanced chronic liver disease in muscle. So there are many patients is increasing now with the obesity and some metabolic dysfunction. Therefore, we targeted for the not decompensated, but in the advanced fibrosis F3 or F4, the compensated patient, we targeted the patient with using this functional enhancement, the stem cells.
Thank you very much.
Yeah, thank you very much for the nice session. I think transplant surgeons are afraid of these results. Okay, thank you very much.
Thank you very much.
Thank you very much, moderators and also speakers.